Good morning, everyone. So, previously we talked about the hypertensive emergency, and in this presentation, we'll talk about hypertensive emergency. So, the hypertensive emergency is an acute marked elevation in blood pressure that is associated with signs of target organ damage. And previously we talked in the hypertensive emergency is that there is marked elevation in blood pressure, but there is no signs of target organ damage. So we have to take in mind that the systolic blood pressure should be greater than 180 mm of Hg and diastolic pressure greater than 110 mm of Hg. And the signs of organ damage includes the features of pulmonary edema, cardiac ischemia, various neurological deficits, acute renal failure, aortic dissection, or eclampsia could be present. The acute worsening of the organ function, if there is acute worsening of the organ function, the blood pressure needs to be decreased aggressively. So if we talk about the hypertensive urgency, the blood pressure should be lowered gradually to prevent dysfunction of the brain from low blood perfusion. So what is the etiology of the hypertensive emergency? So the majority of the hypertensive emergency occur in the patient with already diagnosed chronic hypertension. So the main causes could be non-compliance with the antihypertensive medication and use of the sympathomimetics. The main pathophysiology of the in-organ dysfunction is fully not understood, but postulated hypothesis is that there is mechanical stress on the vascular walls by the abrupt increase in blood pressure, and it leads to endothelial damage, and there will be the pro-inflammatory response, and this would lead to increased vascular permeability, platelet and coagulate cascade activation, and fibrillary clot deposition, which leads to hypoperfusion at the level of target organ tissues. So it will eventually lead to the organ damage. So if you look at the history and physical examination, it is similar to hypertensive urgency. The all history and the physical examination revolves around the if there is presence of the in-organ damage or not. So the examination finding may vary upon specific target organ with most affected part. That means if there is cardiac dysfunction, or if there is lung dysfunction, or if there is kidney injury, then the symptoms will result accordingly, according to the system involved. So acute renal failure may also result in the sign of pulmonary edema or peripheral edema. So we have to see the edema that is pulmonary, or we have to see the peripheral edema in the acute renal failure. So how do we evaluate the patient with hypertensive emergency? So the evaluation for the hypertensive emergency is depend upon the symptom and the sign that is present in the patient. So all of the evaluation is very much similar to hypertensive urgency. So only thing we have to rule out is if there is severe target organ damage or not. So once it is determined that is true hypertensive emergency, so various metabolic panels we have to send, and we have to do the urine analysis, beta natriuretic peptide and cardiac enzymes we have to send. So the ECG is recommended in the patient if there is suspected cardiac ischemia, and head CT is recommended in the patient with acute neurological complication, or if there is neurological complication in the examination. So the chest X-ray may be helpful in the patient with shortness of breath. It can rule out the pulmonary edema if that is present. A chest X-ray may also show widening of the mediastinum in the setting or aortic dissection. So CT angiography of the chest and abdomen should be obtained to rule out and confirm the dissection and to determine the extent of the intimal tear if we suspect the hypertensive emergency is due to the aortic dissection. So how do we manage the hypertensive emergency? So with specific target organ damage, rapid lowering of the blood pressure is the mainstay of the therapy in hypertensive emergency. So our goal would be like decreasing the mean arterial pressure by 20 to 25% within first 1 to 2 hours. So this is with the contrast with hypertensive urgency. So we lower the hypertension, we lower the increase in blood pressure in hypertensive urgency like in 24 to 48 hours. So our main goal say would be the decrease in mean arterial pressure by 20 to 25% within 1 to 2 hours. So what type of drugs we need? We need a drug that is acting rapidly and that is easily titrable. That means we can adjust the dose. We have to choose a type of drug that acts immediately and that is controllable within our reach. So oral medications such as clonidipine, nifedipine, they play no role in the immediate management of the hypertensive emergency. So we have to give the intravenous drips like labetalol, esmolol or nicardipine. So same as the hypertensive urgency, the labetalol is an alpha and the beta blocker that shows a very beneficial in the management of the hypertensive crisis. So it is particularly preferred in acute dissection and in stage renal disease. So we give 10 to 20 mg bolus, or it may be given as IV infusion at 1 mg per minute until the desired blood pressure is achieved. In the pregnancy, the pregnant woman should be given intravenous hydralazine or oral nifedipine. So in the female, we should not treat with ACE inhibitor or ARBs. So what are our various differential diagnoses in the hypertensive emergencies? It could be acute kidney injury, aortic dissection, aortic coarctation, chronic kidney disease, eclampsia, hypokalemia, hyperthyroidism, pheochromocytoma, renal artery stenosis, or there could be the subarachnoid hemorrhage. So there are various issues, related issues, where the hypertensive emergency can occur, and these are the peculiar issues that we have to know about, like in the acute ischemic stroke or acute hemorrhagic stroke, or in case of aortic dissection and preeclampsia. So in case of acute ischemic stroke, there are two patients in the acute ischemic stroke. The patients that are eligible for thrombolysis and patients that are not eligible for thrombolysis. So the patients which are eligible for thrombolysis should have blood pressure lower to systolic blood pressure lower than 185 mm of Hg and diastolic pressure 110 mm of Hg, and maintain systolic blood pressure lower than 180 and diastolic pressure lower than 105 mm of Hg for the first 24 hours. So in the first 24 hours in the acute ischemic stroke, if there is marked elevation in the blood pressure, rapid lowering of the blood pressure is not preferred in the acute ischemic stroke. So the patients which are not eligible for thrombolysis, only levels of systolic blood pressure higher than 220 mm of Hg or diastolic pressure 120 mm of Hg should be lowered at hypertension in acute stroke. So because there is already hypoperfusion in the brain due to acute ischemic stroke, so if we aggressively decrease the blood pressure in the setting of the hypertensive emergency with acute ischemic stroke, then there is more chance of the brain damage in that setting. So we have to take in mind, we have to take in note in the acute ischemic stroke. So the reasonable goal would be to decrease about 15% decrease in mean arterial pressure, not to like 20 to 25%. We do with the patient that is present only with hypertensive emergency. So let's say acute hemorrhagic stroke. In the acute hemorrhagic stroke, we can go to the systolic blood pressure lower than 140 mm of Hg to improve the functional outcomes. So we have to use the medication that is rapidly acting and easily titrable. So in case of the aortic dissection, Intravenous beta blocker, commonly esmolol, are the first line of treatment due to their ability to lower blood pressure while avoiding the reflex tachycardia, and this reflex tachycardia can increase this stress to the aortic wall. So nicardipine with addition of the beta blocker would be the good choice. So in case of preeclampsia, the first line of therapy would be magnesium sulfate, that is administered as a 4 gram to 6 gram as the loading dose, followed by 1 gram to 2 gram per hour infusion. So you have to take in mind of urine output, deep tendon reflexes, and respiratory status. So if any further antihypertensive are needed, we can use beta blockers. So these are my references. So you can go through these references and see the various hypertensive emergency and urgency. So we still have time, so we can talk about how we can manage effectively the hypertensive emergency or urgency in our GPH setting. So today I keep my presentation short and sweet.